Laboratory findings in subacute thyroiditis. In addition to thyroid tenderness, nearly all patients have biochemical evidence of hyperthyroidism, high serum free thyroxine T4 and triiodothyronine T3, and low serum thyroid stimulating hormone concentrations during the early stages of the illness, even though many have few, if any, symptoms of thyroid excess. The serum free T4 and T3 concentrations are usually only mildly elevated, and serum T3 is not typically disproportionately increased as it is in some patients with Graves' hyperthyroidism. Hyperthyroidism is transient, lasting from 2 to 8 weeks, and may be followed by a period of transient, usually asymptomatic, overt or subclinical hypothyroidism, high TSH and low normal or normal serum free T4 and T3. The ESR is usually greater than 50 mm per hour and may exceed 100 mm per hour. C-reactive protein may also be elevated. Other characteristic laboratory findings, although not routinely needed to confirm diagnosis, include high serum thyroglobulin concentrations due to release from the thyroid gland, mild anemia and leukocytosis. Liver function tests are also frequently abnormal during the initial hyperthyroid phase and then typically return to normal over the next 1 to 2 months as the disease improves. The specific cause of the elevated liver function test is unknown but could be related to the viral infection or less likely the hyperthyroidism. Serum anti-thyroid peroxidase or anti-thyroglobulin antibodies are usually undetectable or present at low titer. Some patients have increases in serum anti-thyroid antibody concentrations during the period of transient subclinical or overt hypothyroidism, probably caused by the response to release of thyroid antigens during the preceding period of inflammation. Imaging studies. In patients with subacute thyroiditis and hyperthyroidism, a radioiodine or technetium imaging study will show low uptake, usually less than 1 to 3%, or a faint heterogeneous pattern of radionuclide uptake during the hyperthyroid phase in the absence of previous recent exposure to high iodine containing radiocontrast agents. On ultrasonography, the thyroid appears to be normal or enlarged but is diffusely or focally hypoechogenic regardless of its size. Color Doppler sonography shows low flow during the hyperthyroid phase, whereas Graves' hyperthyroidism usually shows enhanced flow. After recovery, thyroid ultrasonography appearance normalizes.